It's a real pleasure to be here for this really exciting session for the RSI trial. I'd like to begin by introducing the people up on the stage. So Jonathan and Matt are going to be presenting the paper. They are from Vanderbilt University, and this is a group that really have, I think, pioneered this whole process of conducting trials embedded within clinical practice in a way that hasn't been done really anywhere. And it's going to be really exciting to hear them talk about the trial. Alyssa Milford, who's a clinician scientist, and I'm going to say she's a fledgling statistician as well. We've got Liz Ryan, who's our study statistician, who's from Monash University. And then Wangari, who was introduced this morning, who I have not yet had a chance to meet myself, who we've got up on the stage. And then finally we've got Chris Nixon, who on the cards that were provided to me is described as intensivist from the Alfred and lots more which won't fit here. And he told me that he wanted to be introduced as the person who carried me through medical school, because he's my classmate, but really he's a pioneer in medical education and intensivist from the Alfred. So we'll start off, I think, with Matt, who's going to provide the introduction, and very much looking forward to hearing what he has to say.
I'm Matt Semler from Vanderbilt University, and I really appreciate the invitation from Critical Care Reviews and from the Alfred and from Monash University to be here with you all today, alongside John Casey and on behalf of our Pragmatic Critical Care Research Group to present the results of our randomized trial of sedative choice for intubation, the RSI trial. So the RSI trial was funded by the Patient-Centered Outcomes Research Institute and our National Institutes of Health. And each year, more than 13 million people worldwide experience critical illness requiring emergency tracheal intubation in an emergency department or an intensive care unit, 1 of 3 of whom will die before hospital discharge. And nearly all patients undergoing emergency tracheal intubation receive a medication to induce anesthesia for the procedure. But historically, the question of how does that choice of induction medication affect patients' outcomes has been unknown. Etomidate is the induction medication used most in the United States, and etomidate is an imidazole-derived sedative hypnotic agent that acts on GABA receptors. And by some, etomidate has been described as the ideal medication for inducing anesthesia in critically ill adults because it has a rapid onset and it has very little effect on blood pressure. But there's a major concern that has plagued etomidate and its use in critical illness for decades now, and that is that etomidate directly inhibits the enzyme 11-beta-hydroxylase in the adrenal glands, blocking the final step of glucocorticoid synthesis. And even a single dose of etomidate to induce anesthesia decreases cortisol levels for up to 72 hours. And the concern has been, for critically ill adults, does this etomidate-induced adrenal insufficiency or corticosteroid insufficiency translate into worse patient outcomes? And over the last several decades, numerous observational studies have reported an association between the receipt of etomidate for induction of anesthesia and adrenal insufficiency, shock, organ dysfunction, and even death. And that's true overall for critically ill patients, but it's particularly true among patients with sepsis who may be at an increased risk of relative adrenal insufficiency. And this concern about etomidate-mediated adrenal insufficiency and its association with death has been sufficient that some current guidelines for tracheal intubation of critically ill adults recommend avoiding etomidate entirely for the intubation of critically ill patients. And this concern has been so significant that actually in 1/3 of the countries in the G20, including here in Australia, etomidate has either been never approved for use or has been removed from the market because of these safety concerns around etomidate-induced adrenal insufficiency and the fact that it might be associated with an increased risk of death. So just to highlight, it's a little bit of an uncomfortable position. So in the United States, etomidate is the most common drug we use for tracheal intubation. 3 million patients a year receive it. And in several other countries in the world, etamidate's been removed from the market because it's deemed unsafe to give to a single patient. So both of those can't be right? So if you're not going to use etomidate, what do you use? So there are several other options, one of which is ketamine. And ketamine is an agent that acts on NMDA receptors, and it's an increasingly used alternative for induction of anesthesia during tracheal intubation of critically ill adults. And its use is increasing worldwide. I just chose 2 completely arbitrary examples. The first is Vanderbilt, the hospital where John and I work, which switched RED from the use of etomidate exclusively to the use of ketamine exclusively in 2012. And the second completely arbitrary example is here in Victoria, where the ambulance service switched to the use of ketamine as the default induction agent for the entire state of Victoria in 2015. When we discuss ketamine, one of the most frequently considered aspects of it is the effects of ketamine on cardiovascular stability during the intubation procedure. That historically, ketamine has been considered more hemodynamically stable than other induction agents because it increases levels of plasma catecholamines, which can increase blood pressure and increase heart rate during the procedure. However, ketamine is also a direct negative ionotrope and is a vasodilator. And recent observational studies have reported an association between the receipt of ketamine and hypotension during intubation, arrhythmia during intubation, and even cardiac arrest. And how an induction medication like ketamine affects hemodynamic instability during the intubation procedure is actually really important. So of the 13 million patients who undergo tracheal intubation in an ED or an ICU each year, 1 in 5 of those patients will have hemodynamic instability during the procedure, and 10% of patients with hemodynamic instability during intubation will result in cardiac arrest. And for patients who have cardiac arrest during intubation, 25% never regain spontaneous circulation, and 80% die in the hospital. So preventing hemodynamic instability during tracheal intubation is an important objective, and in fact, it's been the main objective of several prior randomized trials, all of which have not been able to identify an intervention that successfully prevents hemodynamic instability during tracheal intubation. But there's a pretty strong rationale that this question, the choice of induction medication, might be one that actually does affect patients' risk of hemodynamic instability during intubation. So with that background, there have been some prior trials comparing ketamine to etomidate during emergency tracheal intubation. The 2 largest of which are shown here. So on the left is the KETASED trial from 2009. The KETASED trial involved 469 patients from 12 EMS services, EDs, and ICUs across France, and compared ketamine and etomidate with regard to the primary outcome of organ dysfunction as measured by the SOFA score, which was numerically a little better in the ketamine group than in the etomidate group, but there was the 4 percentage point difference in mortality favoring ketamine was not statistically significant. And the second was the EVK trial conducted at a single center in the United States, which among 791 patients examined the primary outcome of 7-day mortality and found that it looked to be better in the ketamine group than in the etomidate group, but there was no difference at 28 days. And meta-analyses of the available trials have similarly shown inconclusive or conflicting results, with some in the last 2 years reporting a high probability that using ketamine rather than etomidate would decrease mortality, and others reporting no difference between the 2 drugs. So to address that long-standing important knowledge gap, we designed the RSI trial to determine the effect of using ketamine as compared with etomidate on outcomes for critically ill adults undergoing tracheal intubation. And we hypothesized that using ketamine would decrease the incidence of death and would decrease the incidence of cardiovascular collapse during intubation. So with that background, we'll move to the methods of the RSI trial. So the RSI trial was conducted by the Pragmatic Critical Care Research Group, which is a network of emergency medicine, anesthesia, and intensive care physicians and researchers at 25 centers across the United States. And this group has completed 10 prior randomized trials in emergency tracheal intubation, including 4 that we've been lucky enough to share the results of here at Critical Reviews during prior years. RSI was a pragmatic, multi-center, unblinded, randomized trial comparing ketamine to etomidate for critically ill adults undergoing tracheal intubation that occurred at 14 EDs and ICUs across the United States. The trial enrolled adults undergoing tracheal intubation with use of a laryngoscope and a medication to induce anesthesia, and these were the only exclusion criteria. So if the patient was pregnant or a prisoner, if they were presenting with a primary diagnosis of trauma, if they were allergic to ketamine or etomidate, if the intubation had to happen so urgently that there wasn't time to perform randomization, or if the clinician had already determined that actually for this patient, ketamine or etomidate was either required or contraindicated. The trial was overseen by the Institutional Review Board at Vanderbilt, the U.S. Food and Drug Administration, and an independent Data and Safety Monitoring Board. And enrollment occurred under exception from informed consent for emergency research, and then patients and their families were approached to provide consent for follow-up in 3 and 12 months. Allocation was concealed until the time of randomization, and patients were randomized in a 1-to-1 ratio to either ketamine or etomidate using permuted blocks of variable size stratified by trial site. Clinicians and research personnel were not blinded to trial group assignment after randomization. So in the ketamine group, clinicians were instructed to administer ketamine intravenously to induce anesthesia, and a nomogram provided doses in milligrams for a range of patient body weights that corresponded to a full dose of 2.0 milligrams per kilogram, an intermediate dose of 1.5 milligrams per kilogram, and a reduced dose of 1.0 milligrams per kilogram. And this is the dosing that is recommended in the US FDA dosing labeling. And these are the doses that UpToDate and Medscape currently recommend for induction of anesthesia in critically ill adults. So using this nomogram and also their knowledge of the condition of the patient, clinicians selected the dose of ketamine that was administered. In the etomidate group, clinicians were instructed to administer etomidate intravenously to induce anesthesia, and again, a nomogram was provided that provided the doses in milligrams for a range of body weights corresponding to a full dose of 0.3 milligrams per kilogram, an intermediate dose of 0.25 milligrams per kilogram, and a reduced dose of 0.2 milligrams per kilogram. And again, these are the doses in the FDA labeling information and the doses currently recommended in UpToDate and Medscape for induction of anesthesia in critically ill adults. But using that nomogram, clinicians, with their knowledge of the condition of the patient, ultimately selected the dose that patients received. The primary outcome of the RSI trial was in-hospital death to 28 days. The secondary outcome was cardiovascular collapse during intubation, defined as the occurrence of any of the following between induction of anesthesia and 2 minutes after intubation: a systolic blood pressure less than 65 millimeters of mercury, receipt of new or increased doses of vasopressors, and the occurrence of cardiac arrest. And a trained observer who is not involved in the performance of the procedure recorded the systolic blood pressure and the use of vasopressors throughout the intubation procedure. Assuming an incidence of in-hospital mortality by 28 days of 30% in the etomidate group, a statistical power of 80%, a two-sided alpha level of 0.05, and that missing data on the primary outcome would occur in less than 3% of patients, we calculated that enrolling 2,364 patients would allow us to detect a difference between groups in the primary outcome of in-hospital death by 28 days of about 5 percentage points. The statistical analysis plan for the RSI trial was published prior to the conclusion of enrollment and specified that the primary analysis would be an intention to treat comparison between the trial groups of the primary outcome using a generalized linear mixed effects model with a random effect for trial site, fixed effect for group assignment without adjustment for covariates. So with that background and methods, I'll now turn things over to John to share for the first time the results of the RSI trial.
Thanks, Matt, and thanks to Rob, Steph, and the entire Critical Care Reviews and Alfred Intensive Care Academic Center for inviting us and putting on such a great conference. We'll start with a consort diagram. Between April 6, 2022 and August 10, 2025, a total of 3,439 patients were assessed for eligibility. Of these, 1,072 met an exclusion criterion. The most common reason for exclusion was that the urgency of intubation precluded completion of trial procedures. Of the 3,439 patients who met eligibility criteria, only approximately 100 patients were excluded because their clinician felt that ketamine was required, and only about 100 were excluded because their physician felt that etomidate was required. A total of 2,367 patients were randomized. 1,177 were assigned to the ketamine group, and 1,190 were assigned to the etomidate group. Of these, one patient in each group was found to be a prisoner after enrollment and was removed from the trial population. Of the 2,365 patients in the trial population, 3 patients in each group discontinued follow-up prior to collection of the primary outcome, leaving 2,359 patients in the primary analysis of the primary outcome. Shown here are the baseline characteristics of the patients in the RSI trial. The ketamine group is shown in the left column and the etomidate group in the right column. Baseline characteristics were similar between groups. The median age was 60. Nearly half of patients had sepsis or septic shock. 55% of patients were enrolled in an ED and 45% in an ICU. And just over 20% of patients were receiving vasopressors prior to enrollment. As clinical trialists, this is our favorite slide. It shows the delivery of the intervention in the RSI trial. Adherence to group assignment was excellent. A total of 99.2% of patients in the ketamine group received ketamine. A total of 99.6% of patients in the etomidate group received etomidate. Only approximately 2% of patients in each group received a second sedative, such as propofol, benzodiazepines, or opiates during the intubation procedure. And 0.2% of patients in each group became unstable after randomization and were intubated without any induction medications. This figure displays the doses of induction medications patients received in the ketamine group, the left panel, and the etomidate group, the right panel, in milligrams per kilogram of body weight. The thick dotted line represents the usual dose described in the U.S. Food and Drug Administration labeling information, 2.0 milligrams per kilogram for ketamine and 0.3 milligrams per kilogram for etomidate. The thin dotted lines represent the range of doses described in the U.S. Food and Drug Administration labeling information, 1.0 to 4.5 milligrams per kilogram for ketamine and 0.2 to 0.6 milligrams per kilogram for etomidate. The median dose of ketamine administered in the ketamine group was 1.6 milligrams per kilogram with an error quartile range of 1.4 to 2.0. The median dose of etomidate administered in the etomidate group was 0.28 milligrams per kilogram with an interquartile range of 0.24 to 0.31. The doses of ketamine and etomidate administered in the RSI trial are nearly identical to the doses chosen by clinicians in prior studies that evaluated other interventions, such as the device trial, which compared video versus direct laryngoscopy, and the Preoxy trial, which compared preoxygenation with non-invasive ventilation to preoxygenation with an oxygen mask. In both of those studies, the choice and dose of sedative medication was made by treating clinicians and was found to be a median of 1.6 milligrams per kilogram of ketamine and a median of 0.27 milligrams per kilogram of etomidate, nearly identical to the doses chosen by treating clinicians in the RSI trial. Shown here are additional details of the intubation procedure. Nearly every patient received neuromuscular blockade, with approximately 70% of patients receiving rocuronium and 30% receiving succinylcholine. Oxygen saturation at induction was 99% in both groups. A prophylactic vasopressor bolus or increase in the dose of vasopressors was given to approximately 19% of patients, and 95% of patients were intubated with a video laryngoscope. Now, on to the primary outcome, in-hospital death by 28 days. In-hospital death by 28 days in the RSI trial occurred in 345 of 1,186 patients, or 29.1% in the etomidate group, and 330 of 1,173, or 28.1% in the ketamine group, a difference that was not significant with a p-value of 0.65. This figure shows the percentage of patients without in-hospital death, the primary outcome, for the ketamine group in blue and the etomidate group in gray, from randomization until 28 days after randomization. The incidence of in-hospital death by 28 days did not differ significantly between the ketamine and etomidate groups at any time point. Shown here is data on all location death by 28 days, which included additional data on death following hospital discharge collected from the electronic health record, state death registries, obituaries, and phone calls with patients. All location death by 28 days occurred in 32.2% of patients in the ketamine group and 32.4% of patients in the etomidate group, with an adjusted risk difference of 0.0%. We applied 3 complementary approaches to analyzing heterogeneity of treatment effect in the RSI trial: traditional one variable at a time subgroup analyses, a risk modeling approach evaluating heterogeneity of treatment effect by risk of the primary outcome, and an effect modeling analysis that used machine learning to calculate the individualized treatment effect estimates for each patient based on their individual characteristics. This forest plot shows the results of the primary outcome in 7 pre-specified subgroups: location of intubation, ED versus ICU, presence or absence of sepsis or septic shock, receipt of vasopressors prior to enrollment, adrenal insufficiency, presence or absence of acute neurologic or active cardiac conditions, and severity of illness as measured using the Apache 2 score. There was no difference in the risk of death between ketamine and etomidate in any of the pre-specified subgroups. Of note, the point estimate for mortality favored etomidate among patients with sepsis or septic shock, the subgroup proposed to be at the greatest risk from impaired corticosteroid production following etomidate. Shown here is the primary outcome in the ketamine group in red and etomidate group in blue by severity of illness. There was no difference between the ketamine and etomidate group among patients with lower or higher severity of illness. Shown here are the results of the machine learning analyses used to examine the effect of group assignment on outcomes for individual patients. These analyses were unable to identify any patients who appeared to experience a mortality benefit from ketamine or etomidate. We will now turn to the secondary outcome, cardiovascular collapse. Because the choice between ketamine and etomidate does not appear to impact mortality, the effects of these medications during the procedure takes on greater significance. In the RSI trial, cardiovascular collapse occurred in 202 patients, or 17.0% of patients in the etomidate group, and 260 patients, or 22.1% in the ketamine group. An absolute risk difference of 5.1 percentage points with 95% confidence intervals of 1.9% to 8.3% and a p-value of 0.02. Shown here is the incidence of cardiovascular collapse in the same 7 subgroups evaluated for the primary outcome. Cardiovascular collapse appeared to be greater with ketamine in nearly every subgroup. The negative impacts of ketamine on cardiovascular collapse appeared to be even greater in patients with sepsis or septic shock, for whom the receipt of ketamine increased the risk of cardiovascular collapse by 9.7 percentage points. In patients receiving vasopressors in the hour prior to intubation, for whom the receipt of ketamine increased the risk of cardiovascular collapse by 10.9 percentage points. And in patients with higher severity of illness, as measured by an Apache 2 score of greater or equal to 20, in whom the receipt of ketamine increased the risk of cardiovascular collapse by 10.7 percentage points. Shown here are more detailed data on the impact of ketamine and etomidate on blood pressure during intubation. Use of ketamine increased the incidence of a blood pressure less than 90 by 5.9%, a blood pressure less than 80 by 3.8%, and increased the proportion of patients who had a drop in their blood pressure by 30 millimeters of mercury or more by 9.2%. In short, nearly every blood pressure outcome we measured was lower with ketamine than with etomidate. New or increased vasopressors occurred in 21.3% of patients in the ketamine group and 15.9% of patients in the etomidate group, a difference of 5.4 percentage points. Ventricular tachycardia between induction of anesthesia and 2 minutes after intubation, a post hoc safety outcome added after the enrollment of the first 567 patients, occurred in 9 of 884 patients, or 1.0% in the ketamine group, and 2 of 905 patients, or 0.2% in the etomidate group, an absolute risk difference of 0.8 percentage points that was statistically significant. Cardiac arrest between induction and 2 minutes after intubation, and cardiac arrest occurring between induction and 1 hour after intubation were both numerically more common in the ketamine group, but these differences were not statistically significant. There were no significant differences in systolic blood pressure at 24 hours after intubation or in the proportion of patients receiving vasopressors at 24 hours after intubation. Successful intubation the first attempt was 86% in both groups. The time from induction to intubation was significantly longer in the ketamine group at 112 seconds compared to the etomidate group at 103 seconds, and that difference was driven by the time from induction to laryngoscopy, with no difference in the time from initiation of laryngoscopy to completion of the intubation procedure. There were no differences in the lowest oxygen saturation or incidence of hypoxemia between groups. Shown here are the free day outcomes, all of which were similar between groups, including vasopressor free days, which was a median of 25 in both groups. So, in summary, the RSI trial was a 2,365 patient randomized trial conducted in 14 EDs and ICUs in the United States. It demonstrated that use of ketamine for induction of anesthesia of critically ill adults did not reduce mortality compared to use of etomidate. Overall, at any time point, in the hospital or after discharge, in any subgroup or for any individual patient based on his or her unique characteristics, so-called individualized treatment effect estimates. Ketamine, however, did increase the incidence of cardiovascular collapse during intubation by 5 percentage points, with bigger effects among patients with sepsis, pre-existing shock, and high severity of illness. These results are important because millions of critically ill adults were intubated in EDs and ICUs each year worldwide. Concerns that etomidate-induced corticosteroid insufficiency could increase patients' risk of death has led guidelines to recommend ketamine over etomidate and led countries to remove etomidate from the market. Our trial found no difference in death between patients assigned to ketamine and those assigned to etomidate. However, we did find a difference in cardiovascular collapse, which occurred more commonly during intubation with ketamine. Using etomidate rather than ketamine could prevent tens of thousands of patients each year from experiencing cardiovascular collapse during intubation. We want to thank the funders of the trial, the Patient-Centered Outcomes Research Institute, PCORI, and the NIH, the hundreds of members of the Pragmatic Critical Care Research Group who performed the trial, our patient partners who helped design and conduct the trial, and the thousands of patients, families, and clinicians who contributed to this research. Finally, we want to thank the New England Journal for their assistance and announce that the results of the RSI trial should now be available on their website. Again, thank you to Rob, the Critical Care Reviews team, and our host here in Melbourne for inviting us to speak and putting on such a great conference. We look forward to hearing thoughts from our editorialist, Chris Nixon, our expert panel in the audience, and thank you all.
Chris, you're up.
So I've got my Nashville uniform on. So let's get stuck into it. So first of all, I'll bring this down from Semler height. So huge congratulations to these guys, Matt, John, your entire team, the whole Pragmatic Critical Care Research Group. You know, a fantastic paper, a fantastic trial, and worthy of publication in the New England Journal. But more than that, this is just one link in a chain of a whole research empire now, I think. You got like over 20 trials from this group with over 50,000 patients that are really tackling real-world problems that matter to clinicians and to patients. And I think that if, I can think of someone who might be looking down on us saying, look, you guys are turning random care into randomized care, and we're learning from it. So thank you. Just before I get stuck in, just this year, this group published a really nice, concise summary of the evidence base for emergency intubation, which is a lot of the work that this group has actually done. It's a really nice summary. That's the PubMed Central number if you want to look it up. And it's also got a lot of the outstanding questions, which maybe points to what they'll be doing next. But I've showered them with all this praise and stuff now. They're probably getting a little bit suspicious, like, is this the first layer? Is this the bread in the shit sandwich? But I would argue it's more like Vegemite on toast, which admittedly to Americans probably tastes much the same. However, Vegemite's good for you. So does this trial matter? Well, look, they've stated the case quite strongly already, but more to the point, I mean, which critical care physician out there doesn't love arguing over the minutiae of how they intubate and all the drugs and stuff they use? There'll be people up at 4 in the morning all around the world, trying to make sure that everyone else knows that they're wrong about this stuff. So one of the downsides of these trials is that there may be less to argue about, or maybe not. But yeah, look, it's a big problem, I think, particularly in the critical care group, this issue of hemodynamic stability and intubation. And look, at least up to this point, ketamine and etomidate have been the two front runners. So putting them head to head, I think, is giving us a lot more great information. There has been this problem with etomidate, obviously, the specter of the adrenal suppression, and that's why this slide here summarizes my personal experience of the use of etomidate, because it's not available in Australia. So what do? Well, I use ketamine. And, this is a major feature of our Alfred ICU intubation guideline, also our emergency packs, and it's supported by a lot of other guidelines around the world at this stage. So you can probably guess where my biases are coming into this. I now want to talk a little bit about my key take-homes, starting with sort of the outcomes. So look, if you're a real desperate ketaminophile, you'll be hanging on to that 1% point estimate favoring ketamine, but unfortunately, no, there is no difference, as we've heard it stated. So there's no difference in mortality between these two agents in this trial. My other key take-home, though, is that hemodynamic compromise can occur with essentially any induction agent. So if we look at, again, what happened with ketamine and etomidate, so etomidate was the best performing drug here, but still 17% of patients met this definition of cardiovascular collapse. So what that means is that whenever we embark on intubation of a critically ill patient, we need to resuscitate before we intubate. We need to be prepared to act when best laid plans go awry. The other key take-home is that in this trial, cardiovascular collapse was clearly more common with ketamine than etomidate. And as we heard, the number needed to harm for this outcome was 20, and in certain subgroups with sepsis or the more severe Apache scores above 20, the NNH was 10. And it doesn't really matter how you cut it. So, etomidate did better than ketamine. So the cardiac arrest outcomes are fairly similar in those groups. That's probably the really patient-orientated, important one. But I think the other outcomes, vasopressor use, and particularly the hypotension, they are important as well. I certainly am not happy if I intubate someone and the blood pressure goes below 65, put it that way. So I think that these are important. They can certainly be a big distraction and require immediate treatment in the context of managing a complex patient. So I want to talk about some of the good stuff, but I don't want to linger on this too long, so we'll start with the bread. There is a whole lot of really good stuff about this trial. You know, it's a randomized, multi-center trial. It's got patient groups that are very much make sense to me. Almost half of them had sepsis. About 22% of them were on vasopressors. They were all intubated with video laryngoscopy by sort of authentic ED and ICU teams. So, look, the patient group makes sense. Allocation concealment, baseline balance, it's all good. Intention to treat analysis, their follow-up completion rates was greater than 99%. Treatment adherence was greater than 99%. The procedures are extremely well documented in this, 94-page supplement. Move over Leo Tolstoy. There's a lot of stuff in there. All these various analyses, sensitivities analyses, heterogeneity, treatment effect analyses that I'll let bigger brains talk about later. And the interventions were standardized. You know, they're clearly described. They're consistent with what the drug packet says, what's done in clinical practice. This is the sort of trial that could make America great again. Now, I've got the power calculation there down as a good thing because they had a good estimate of what the event rate would be, and they also took into account what pre-existing studies would suggest maybe the mortality harm from etomidate would be. But look, this is where we want to get to. We want to get our spoons out and get stuck into the Vegemite. So these are some issues to consider. And I've got to admit, I'm scraping the bottom of the Vegemite jar for some of these. But look, probably the only real threat to internal validity here would be that the observers were not blinded to the drug. But, it's a pragmatic trial. I think we just have to take that on board. Could there be some selection bias? Well, we already heard that there were probably over 300 patients who just need to be intubated so quickly that they couldn't be included in the trial. And then we've had another group of patients, about 240 odd, which represents about 10% of those that were randomized, where clinicians knew which was the right drug for those people. So that is going to have some impact on our external validity when we think about who this actually applies to. And I'd be really interested to know if there was more information about what that decision-making by clinicians involved, especially in light of maybe some paradoxical findings that were found. So the power, good rationale for the calculation, but look, if there was a 1 or 2 or 3 or 4% mortality difference between these drugs, that would probably push me to one or the other. There were no trauma patients in this trial, so keep that in mind when you apply it in practice. And a thing that's a little bit different to say what would happen in my part of the world is that most of the patients had non-rebreather masks for pre-oxygenation. Why could that be relevant? Well, we know in the pre-oxy trial that using CPAP for pre-oxygenation, it was still pretty hemodynamically stable, but 75% of those patients got etomidate. So if anything, it could maybe make the ketamine outcome even worse if they were getting positive pressure. This trial is only about rapid sequence intubation. So what does that mean? That means choosing a dose of a drug, pushing it, giving the paralytic, and then dealing with what happens next. So it's not talking about little titrated doses and sort of a delayed sequence intubation approach, which I may come back to shortly. But the thing that I really want to talk about here is drug dosing. So again, there's a strong rationale for what they did in the context of a pragmatic clinical trial. They used the drug doses that are used in clinical practice, that are in the literature. For ketamine, it's 1 to 2 milligrams per kilogram. So you can't argue with that. However, they used dosing based on actual body weight. Now, this is an area of uncertainty. I think people, I'd put my hand up and say, I don't know for sure whether it's better to use actual body weight or to use ideal body weight. There are certainly guidelines, including pre-hospital guidelines endorsed by organizations like ACEP, the American College of Emergency Physicians, that recommends ideal body weight, and that's what we use in our guideline at the Alfred ICU. Now, why would you use ideal body weight, given that this is a lipophilic drug? It kind of makes sense just from a pure volume of distribution that total body weight may be better. But what happens with ketamine is that when you give it, it goes straight to the brain. So it goes to the brain first, that's why it works rapidly, and then it redistributes from the brain to the muscles and then the fatty tissues of the body, and that's what contributes to its more rapid offset. So I would argue that giving it total body weight is giving bigger doses, having a bigger effect on the brain, and that could be relevant, especially when you look at the fact that the median BMI was 26, so about half of patients are overweight, and then about a quarter of the patients were obese in the study. And then the doses are even bigger when you look at what was actually given on a milligrams per kilogram basis, because about a quarter of patients actually got more than the 2 milligrams per kilogram actual body weight. So I'd be really, really interested if you guys have anything on the dose dependence of the cardiovascular collapse. So I finally want to wrap up by a little comment really saying, look, is rapid sequence intubation what we should be doing for patients who are at risk of hemodynamic compromise? So when we give an induction drug, that's really about making things nice for the patient. You know, it's so that they don't have awareness, that they don't experience pain during the procedure, and that hopefully that they don't remember it. Those things are great. You know, we want to achieve those, but even more important is having a patient alive and not having significant physiological compromise. And one of the great things about ketamine is that that when you give it to patients, they'll often continue to breathe spontaneously, so you can give smaller doses and titrate it to effect, and then when you think that the drug is working, maybe seen the hemodynamic effects, that's when you can push the paralytic and intubate them. And that also buys you time, particularly if they're not cooperating with pre-oxygenation, to get them in a state where you can actually oxygenate them effectively. So for me, in my practice, I would tend to use lower doses, and in the patients at risk, titrate the doses up. But the question is, how do we identify those patients at risk? And is delayed sequence intubation really safe? Because there could be, we've got to make a trade-off between hemodynamic compromise and obviously aspiration risk, which is what rapid sequence intubation is all about guarding against. So there's probably some room for more studies here, I suspect. But I guess I can't get to the next slide. But I'll finish there because my last slide was going to be like, who wins? And well, these guys win, obviously, because they've done an amazing trial and it's published in the New England Journal of Medicine. But we all win because we learn more about this condition. And I think if you're a etomidate user, you're going to be reassured that there's no mortality difference. You're going to be a bit smug about the fact that it appears to be more hemodynamically stable. And look, we probably haven't learned much more about the significance of transient adrenal suppression, because that could still be a bad thing, but maybe offset by other benefits from etomidate. And then if you're using ketamine, well, we've got to think about what drug doses we're using, identifying at-risk patients, and thinking about whether rapid sequence intubation is the way to go. Thank you very much, and thank you, guys.
So, Jonathan and Matt, I'll give you an opportunity to respond briefly to the editorial/love letter just received.
We'll start by saying we agree. Is that? Chris, thanks. Those were a lot of very kind comments and a lot of really important comments. So we'll do our best to respond to them. So I think you brought up a lot of important issues that we thought about during the design of the trial and heard about from reviewers during the submission process. And I'll start with blinding. So I think the decision to blind this trial, to not blind in this trial after enrollment was an important decision to discuss. So first, what's the benefit of blinding? Blinding is most important when you worry that the outcome measurement could be affected by knowledge of group assignment. So certainly if this was pain or some other subjective assessment, you'd really worry about observer bias from lack of blinding. One outcome that historically people have said blinding is less important for is mortality. So it's hard to measure mortality differently based on knowledge of group assignment. And even a lot of the key secondary outcomes, like lowest blood pressure, are pretty objective. The second part is, how would you blind in this trial? It's already hard to do all these trial procedures embedded in clinical care as part of an emergency procedure. But even if you did, there's the additional challenge that the way people dose reduce these medications is different. So you could give them a blinded vial, and in the ketamine group, the range is from 2 milligrams per kilogram to 1 milligram per kilogram. So they might dose reduce by as much as half. In the etomidate group, the range is from 0.3 to 0.2, so reducing a fully reduced dose is only a 50% reduction. So it's really not easy or feasible to blind these medications, or if you do so, it's not just blinding, it's changing the way they're used in care, and it will result in doses of medication that are different than the doses those patients would have received as part of routine clinical care. So we really considered it and felt on balance that there wasn't a lot of benefit and there were real downsides to blinding. So that's the rationale for why we didn't blind. And I'll maybe tackle one more and then let Matt address a few points, and that's around the power of the trial. So you highlighted that there was this 1% difference, and then graciously said that you also agree that there's not a difference overall. But I think it is important to note that the trial is powered for a 5% difference in mortality for drugs like this that are given to millions of patients every year. It's certainly feasible that there are small differences that our trial was underpowered to detect. But I'll say, at least personally, I feel very reassured by the subgroup signals. So if there was going to be a difference in mortality, you would expect to see it for the people who are highest risk for mortality, like those with high Apache 2 scores, those who had sepsis. And a lot of the reason we got where we are today is because prior research, like the Ketoset trial, suggested harm in patients with sepsis. The Ketoset trial had 76 patients with sepsis. There are more than 1,000 patients of sepsis in the RSI trial, and the point estimate for mortality favors the etomidate group. And even if you felt like those two factors by themselves, age and severity of illness, might not be the most important, we did these advanced machine learning methods that still were unable to detect any individual patients that benefited. So to me, the results are what they are. So we can look at our confidence interval and know what kind of mortality difference has been ruled out. But I don't see any signal in any of our data that there is any further reason for concern around mortality. So maybe I'll stop there and let Matt take a couple.
Sure. First, Chris, thank you so much. Really appreciate the comments. And the two that I wanted to tackle that I thought were really important you raised were the idea of who's in the trial, looking at that consort diagram and who might be excluded, and then drug dosing. So one of the potential threats to a trial is that you always have to allow clinicians who know the right answer for an individual patient to not enroll that patient. That at least especially for these types of trials, clinicians have the option when they know the right answer to not have their patient participate, but if that occurs in 90% of the patients and the only patients left in the trial are those for whom it doesn't matter, you don't have the ability to distinguish between groups. So I think it's really important that only about 100 of the 3,000 patients were excluded because the clinician thought they needed ketamine, about 100 and we did collect and report those reasons, so thank you for making it through the 94-page supplement, and for those who are interested, Figure 1 in the figure legend reports the reasons for every individual patient. And what's interesting about those reasons is what's the most common reason why ketamine was required? Well, it's because the patient was hypotensive. So it tells us about what our prior beliefs are. So I think look carefully at those, but those I think don't suggest that clinicians were accurately identifying those patients who ketamine would be beneficial for and then excluding them necessarily. So for those who are interested, we report those, but it I think should be a reassuring description of who is not in the trial.
And they overlap. So people will often exclude a patient because they were unstable or had high increase in intracranial pressure, and that'll be a reason given for exclusion for the requirement of ketamine and for the requirement of etomidate.
In equal numbers, right. The second and the huge question is around drug dosing. And so you correctly described the approach we took to this was basically to provide guidance around the doses that are recommended in the US FDA labeling, but have clinicians make the ultimate determination. And our hope was they would result in doses that were similar to what clinicians would have used had a trial not been occurring, because we wanted to understand what are the effects of using these drugs in practice. So we were very relieved to see that they were almost identical to prior trials in the same settings. But your point is a good one, which is, well, what if I'm somebody who uses a lower dose of ketamine, let's say, could I expect the same hemodynamic effects? And the place that I'm glad we have additional information is the EVK trial had a similar dosing regimen, but their clinicians used smaller doses. So in the EVK trial, it was a median of 1.1 milligrams per kilogram of ketamine and a slightly dose-reduced etomidate. And although it wasn't a big focus of the trial, they saw the exact same differences in hypotension, vasopressor receipt. They actually called their cardiovascular outcome the Vanderbilt definition, which is not what we've called it. So it's the same outcome measured in a trial that used about a substantial reduction in dose and saw the exact same hemodynamic effects. And so I found that reassuring that this is probably not because people are getting unreasonably high doses of ketamine.
Great, those excellent conversations. So we're going to move now to some questions from the audience. Looks like we're starting with questions from Twitter.
So there's a lot of questions online, but we've got a couple first. The first is, cardiovascular collapse becomes more significant to me when I need to start CPR. Was there a difference in the incidence of CPR required between groups?
Yeah, that's a great question. I think it's really important because you might ask, well, does cardiovascular collapse matter? So if someone experiences hypotension during this 4-minute interval from when we push drugs to when we've seen their lowest blood pressure during intubation, but they recover, does that have harm? There is a lot of evidence that it may have harm, but we don't see clear signals of that in our trial. But what we do believe is the same as that the person asking the question, that the most devastating complication of intubation is cardiac arrest. In study after study, including international studies like the INTUBE study, it occurs in up to 2 to 3% of patients. So there aren't many things we do in medicine where you walk in the room and are talking to a patient who's awake and know that in the next 2 minutes they have a 1 in 50 chance of dying. So it's really a high-risk procedure. And the biggest risk factors for cardiac arrest are hypotension and hypoxemia. However, if you were going to power a trial to look for differences in an outcome that rare, that in our trials occurring in 1% of patients, you would need to enroll tens of thousands of patients. So really, it's not feasible at present, even using our pretty efficient methods, to do trials that target differences in cardiac arrest. But we believe strongly that if you prevent these risk factors, you will affect that downstream outcome. And we saw the same thing in our trials around hypoxemia. So we did trials of several hundred patients that prevented hypoxemia, and there were numerical differences in favor of the groups that prevented hypoxemia for cardiac arrest. And then eventually in the Peroxy trial, we did a trial that was large enough and showed that when we prevented hypoxemia, we also prevented cardiac arrest. I think the same is probably true here, that we're now preventing cardiovascular collapse with an absolute risk difference of 5%. There's numerically less cardiac arrest. We can't make strong claims on that. But I believe in my heart of hearts that if we had done a larger trial, large enough trial, that by preventing hypotension, you will prevent the thing people care most about, which is cardiac arrest.
And the second question was around the amount of fluid received at the time of induction, recorded in patients analysed in both of the arms, but particularly in the septic shock group.
So, yeah, that's a great question, and we think about this in phases: the resuscitation prior to the procedure, the prophylactic fluid bolus, the administration of fluid during the procedure to treat hypotension, and fluid received after. So this is because we thought that sepsis subgroup is a really important part of this. There's a separate ancillary study that we're in the process of, which is collecting information on fluid and treatment of sepsis throughout this process. So we don't have that data yet. That's ongoing, but we realize it's important. The only thing I would highlight in this is that we mentioned during the talk that there have been trials trying to assess interventions that prevent hypotension during intubation that have not succeeded, and 2 of those were our trials of fluid bolus to prevent we were so certain we had to try and prevent cardiovascular collapse and so sure fluid would work. We did that trial twice, and it didn't work either time. So I think that's the one thing I'll say about fluid is fluid's very important in sepsis and its management. Fluid does not prevent hypotension during intubation.
And I keep reminding Matt we're not doing it a third time.
It's one more time.
Steve.
Very, very impressive trial. You outlined how etomidate may have an adverse impact on cortisol production. That creates the substrate for a possible interaction between concomitant therapy. Do you have any information on subsequent use of corticosteroids and whether it's differential between the two groups?
Yes, this is a great question. You can see me flipping to my notebook because we recorded this at every time point you could ask for and report it in detail. The proportion of patients who were on chronic steroids was 10% in each group, so that was prior to their acute illness. The proportion of patients who had received steroids in the 48 hours prior to intubation was 20% in each group. The proportion of steroids who received proportion of patients who received corticosteroids at any point after their intubation and between intubation and 28 days was 45.9% in the ketamine group and 49.5% in the etomidate group, a 3% percentage point absolute difference that was not statistically significant.
So clearly no differential effect, but potentially if corticosteroids were offsetting adverse effects of etomidate, it may affect external validity in locations with less corticosteroid use.
Yeah, that's a great question. And we did look at a subgroup of patients who were those who had not received corticosteroids prior to the procedure, and there was no heterogeneous treatment effect by prior receipt of corticosteroids.
I think you're exactly right. It's certainly plausible that clinicians are recognizing hypotension, treating it with steroids as a routine part of clinical care, and that could be masking any deleterious effects that could have been present in prior research.
If they are, it's masking an effect that is not relevant in this context. It's the combination which becomes effective.
Bala, I guess.
Thank you. Great trial, fantastic presentations. Just going on Steve's point, I think a bit of perspective there. So when etomidate's effects were first reported back in '83 by Ledingham, it was in patients with multi-trauma, where they reported excess mortality. And I think trauma was excluded from your cohort. I think that's probably worth keeping in mind. The second thing is, if you go back to the first Anand trial in septic shock, the first French trial, 25% of the patients received etomidate. And the mortality benefit was only seen in those patients with relative adrenal insufficiency. So where obviously giving steroids made a difference. So I think the additional 3 or 4% who received steroids in the etomidate group might actually have an impact downstream, although it's obviously not big enough in the size that you've got there. But this is something to keep in mind. And did you measure adrenal function out of interest?
So that's a great set of questions, and trying to answer them in order. You're exactly right that this was originally identified in a group in patients with trauma and replicated in non-trauma patients. That was all in the context of etomidate continuous infusions, right? So that's a very different intervention, and I think nothing about our trial tells you anything about the safety of the use of etomidate as a continuous infusion. The adrenal insufficiency component was measured and really well characterized in the Ketased trial and in other work. And in the Ketased trial, adrenal insufficiency using ACTH challenge occurred in 40% in the ketamine group and in 80-some% in the etomidate group. So this is a huge difference in the proportion of patients who, at least for a short period, have evidence of adrenal insufficiency. And so I just contrast that. So there was a 3% difference in the receipt of corticosteroids, but we'd expect a 40% difference in the presence of adrenal insufficiency. So I think that's not covering that gap. Would you add anything?
Yeah, I would just highlight that I think people who practice in locations where etomidate's not available may not recognize that history, that it started its use as a continuous infusion, and as a continuous infusion, the effects on adrenal insufficiency are dramatic. So dramatic that at least in the US, when we have patients with an adrenal crisis, we often use an etomidate drip as a treatment of adrenal crisis.
Just clarify, adrenal crisis is if there's a tumor that is producing too much cortisol,
yes.
then we use etomidate as an infusion to block the cortisol
Yes,
production.
thank you.
Yes.
So we use it to bring down cortisol levels. As a one-time dose, the definition of adrenal insufficiency in some of the trials like Keita said is controversial. It clearly has an impact. Whether or not it meets clinically diagnosable adrenal insufficiency has been variable between studies. But that effect has been so reproducibly shown, we didn't feel like there was additional value in measuring in this study. So the real question that remained was not whether it affected cortisol. It does. That has been so well shown that we didn't feel the need to show it again. The question was whether that mattered for clinical outcomes.
Okay, so I'm actually going to bring things back to the panel at this point. We might go back to the floor a bit later, but I guess one thing that I wonder if it might be reasonable for us to think about as a panel, right, is having sat through the presentation and the editorial on the questions and stuff so far, I wonder if people would sort of agree broadly that if you want to have a cardiovascular stable induction, that on the face of things it seems like etomidate might well be a better choice than ketamine. I'm interested to hear the extent to which people on the panel agree or disagree with that statement, and any particular caveats or, I guess, exceptions to the rule that they'd like to apply. We'll just go through the whole panel. Everyone can have a turn. Chris, we'll start at the end. We'll move this way.
No, you've heard from me. Start at that end.
All right, I'll go. Yeah, it's a good question. Would it change my practice? Probably not where I work at the Royal Brisbane and Women's Hospital, but my other area of practice is with the Defence Force, which is quite a different setting, so features high incidence of trauma patients who are likely to be hemodynamically unstable. Also features smaller teams, inexperienced practitioners, so as in some of our doctors are, a lot of our doctors are junior doctors who may find themselves alone and having to intubate patients by themselves with medics to support them, and therefore not able to rescue patients who become hemodynamically unstable. So etomidate may actually be beneficial in that setting, but unfortunately...
So can I draw you on that then?
Yeah.
So we've heard that the signals of danger came from trauma, and trauma are excluded.
So we don't know.
And now you're saying trauma. Well, I'm interested in hearing whether you reckon that's okay, and also from these guys as to whether they reckon that's a reasonable extrapolation to make.
Yeah, well, I guess we can't say from this trial whether trauma...
Yeah,
because they were excluded, so... but I guess theoretically, they're going to be the group that are going to be hemodynamically compromised. I would be interested to hear what you guys think. Is that a reasonable conclusion to make, or should I put the etomidate away and stick to...
Well, we should maybe start by saying why we excluded trauma patients, which I'm not sure we fully explained. So there has been concern going back to animal models and observational studies. People have believed that ketamine induces hypertension at a greater rate than other induction medications. And that's along with the belief that it's a more hemodynamically stable drug than many other medications. And there's some evidence that support that. So the Keita trial enrolled all comers, and they included trauma patients and septic patients, and they had opposing signals. So in the Keita trial, among patients with sepsis, the mortality was 7% higher with etomidate, and in patients with trauma, it was 4% lower. So we really believe that it might be important in both populations and could go in opposite directions, but the causal pathway for that would be increased intracranial pressure in trauma patients, related to the increased catecholamines and increased levels of hypertension. So that's why we excluded them. What did we find in our trial? We found the opposite. We found that ketamine had caused more hypotension every way you defined it, and we also looked separately at hypertension, the highest blood pressures, and the proportion of patients who had blood pressures above 180, and there was less hypertension with ketamine than with etomidate. So that prior concern didn't bear out, and I think had I known that, I probably would have included trauma patients in the trial. And I think our trial doesn't inform directly how trauma patients should be cared for, but I think it's probably the best indirect evidence available. And if I were choosing a medication today, like you, I think it'd be reasonable to say that I might choose etomidate.
You would choose etomidate, okay.
okay. What about you, Liz? What do you reckon about that broad clinical message and maybe some caveats from a statistical perspective?
Yeah, it's a really interesting trial. You enroll to your target sample size. Your statisticians turn those analyses around really quickly, so congratulations to them. You only finished recruiting in August, so that's very impressive. Your estimated mortality rate for your sample size was only 1% different to what you ended up with, so that was really cool. You didn't really have many issues with non-compliance, so that was good. We didn't have to deal with those funky issues as well, so that was nice. I think one of the questions I had was death in any location by 28 days increased by an additional 3 to 4% compared to the in-hospital 28-day mortality. Do you have any, it was the same in both groups, pretty close. Any reasons why there was that further increase in the mortality?
Yeah, I can talk about that. So I think we talked about this a little bit in the session the other day about the iRehab trial, how for critically ill patients, there is this period of really high risk of mortality as a result of their critical illness, but that risk doesn't really go away, and actually probably doesn't go away for months or even a year afterwards. So obviously we're following these patients for a year, and we anticipate that patients after they discharge from the hospital will have intercurrent illnesses. And I think, and we saw that the in-hospital mortality was slightly lower than the all-location mortality, although neither of them was different between groups, and if anything, the all-location was more reassuring about no difference. But I think the question of at what time point and in what location has to do a little bit with what the expected effect of interventions are, and I think the further we get out from this one-time intervention, the less likely that those deaths are attributable to the choice. So I think we will collect mortality out to 1 year, but I think it's very unlikely that deaths occurring very far downstream are attributable to these medicines. Yep. That makes sense.
Okay. Wangari, what are your thoughts?
Thank you. Great trial.
Yeah.
Really good trial. Well, for obvious reasons, my practice won't change. We don't have etomidate widely available in my country. It is there in certain centers. My hospital has it because we have a cardiac surgery program, but it's not widely available. So I'd say we've gotten good at using ketamine. Like Chris says, we use low doses. I would never use 1 per kilo, probably 0.5 milligram per kilo. And I always use a chaser. So the ketamine goes in goes something straight away. I don't wait for the hypotension. So we've gotten good at it. And again, like Chris said, almost any sedative can give you hypotension. Some patients, they're so sick, they're surviving on their catecholamine drive. So the moment you sedate them, cardiac arrest is imminent. I think I did have one question for you, and maybe I misunderstood. I think you mentioned that some patients were intubated with combinations that included propofol and even opiates. And I found that rather interesting because I wouldn't touch propofol in these patients. But was it because they were hemodynamically stable to start with that clinicians thought etomidate and propofol, ketamine and propofol, and to what dosage?
Yeah, thank you. We'll answer both of those, and I'll go first, and John, you can chime in. I want to be really clear that the number of patients who received propofol for induction in this trial, I think, is 1 in each group or something like that. So when we said 2% received another medicine, that's mostly midazolam or benzodiazepine in addition, and that's only 98% of patients received only ketamine or only etomidate. So really not use of propofol, which is used in the INTUBE study internationally. Propofol is the most commonly used induction medication in a lot of settings, but that's not familiar to us. The piece about the availability of etomidate in different settings, I think, is central to this. That kind of started this question for us, and I'll point out, so I think this is true, that ketamine is on the World Health Organization list of essential medicines, and is part of the reason it is available across settings. And etomidate is not on that list, and I think these concerns about adrenal insufficiency are part of the reason that etomidate is not on that list. So I think, this is not my place to think about, but as we've been sitting with these results, we're wondering, there are huge hundreds of millions of people who their countries have not allowed access to etomidate. I'm not sure if this is enough to change that. But that idea of if this is the right induction medication, this is kind of a political or regulatory issue as much as it is a clinician choice issue, if that makes sense. John, what would you add?
The only thing I would add is that if I heard you correctly, you often will administer ketamine and a prophylactic vasopressor. Is that what you said?
Yes. So
And that's a common approach in some settings. You know, some of our hospitals do that in every patient. Some essentially never do that. So you might expect it's a question that we're interested in studying. And I think it's certainly plausible that that could prevent some of the negative impacts of ketamine, or it may not. There's some observational studies that say vasopressors given prophylactically aren't as effective as you might hope, or could increase the risk of other problems like arrhythmia or cardiac arrest. So I think I hope we study it, and I hope you're right. I hope it helps. And it's certainly a common approach that lots of people use. I think it also reminded me that the treatment of hypotension during intubation requires experience and availability of medications. So one thing that's been pointed out to us is that these patients were all enrolled in academic, high-resourced EDs and ICUs. And it's certainly plausible that in the pre-hospital setting or the combat setting or settings where there's less experienced people and less availability of vasopressors, you may see bigger differences in outcomes between ketamine and etomidate.
Yeah. Chris.
So just going back to your original question, so if you held a gun to my head and I had to do one of those two options, I'd take the ketamine option, the etomidate option. But I don't do either of those options currently, I would say. Like, it would be very rare that I'd give over 100 milligrams of ketamine in my setting when I intubate someone. You know, one of the things that I may do is look at changing our guideline from what the maximum dose of ketamine that we'd suggest. Because we say in patients that we're concerned about shock or hemodynamic compromise, we'd start off probably with no more than 0.5 milligrams per kilogram, and sometimes you'd even just use 20 and do little titrations up. Now, I've got a question for you guys as well, because I know you're going to do follow-up. And so I'd be interested if you're going to look at awareness, because one of the issues that we have is that with ketamine, it's hard to know, actually. You know, you can't put EEG monitors on, it's not reliable for assessing depth of sedation. But one of the advantages of ketamine, if you use lower doses, is one, you take away all pain. It's a fantastic analgesic. And then probably at around the 0.3 to 0.5 mg per kg doses, you're going to get loss of memory, amnesia, and then somewhere around usually 0.5 to 1, we think that you probably get loss of awareness. But then there's lots of other crazy stuff that could be going on in their head that we don't know if it's real or not, because you get bad nightmares. But there was some studies in the early 2000s, summarized in this nice article called Shock Values by, I think it's Schaefer, 2004, where they had these pig models where they bled them down to a systolic of 50. And one of the things that they found with putting like BIS monitors on these pigs is that etomidate, you can't reduce the dose. So you're going to get higher awareness if you try and reduce the dose of etomidate. I don't know if that's the case for ketamine or not. With propofol, it actually gets more potent in that hemorrhagic shock model. But I think we need to know maybe a little bit more about this awareness issue in ED and ICU, which is probably, with these short-acting agents, more about not starting sedatives after they've been paralyzed. But I think that's an area where, because really these drugs are really just there to take away awareness. Otherwise, you don't need them.
Yeah, so that's a fantastic question, and education on the whole backstory of that in and of itself. So I think, yes, the purpose of our 3 and 12-month outcomes is in part to evaluate that question. So we have only recently realized that somewhere between 5 and 10% of patients who undergo emergency tracheal intubation have awareness with paralysis. That is, that they remember the experience of the intubation procedure or being paralyzed and mechanically ventilated and unable to move. And that, in some studies, has been a risk factor for the development of PTSD after critical illness. And for several mechanisms that you described that differ between ketamine and etomidate might affect each of those risks, right? So the half-lives of those drugs are different, and so the probability that you're not adequately sedated while you're still paralyzed is probably different between the two drugs. The ketamine, in addition to the things you mentioned, prevents the formation of traumatic memories, and you can imagine that getting that at the onset of critical illness might prevent the development of PTSD. So I think as part of the long-term follow-up study, we are collecting Bryce questionnaire and measures of awareness with paralysis, and then the development of PTSD and at the 3 and 12-month time points, and are really interested to see. And this, we should acknowledge that could change the decision-making here too. So if there is no difference in death, and there's a difference in cardiovascular collapse, but a difference in the other direction in favor of those patient-centered outcomes, that might change the weighting of that choice of which drug to use.
Yep. So I'm going to take the prerogative of the chair to ask a question myself. So I'm really struck by the opportunity that exists here, because at a global public health level, right? Because this is a medication that is in many places not been available, that now, you know, I think you'd have to say potentially at scale being rolled out in situations, you know, maybe middle income countries and stuff like this, there might turn out to be, you know, major benefits associated with implementation of it. So I'm sort of interested in hearing about, you know, what you think about those opportunities, but I'm also interested in understanding your view of the generalizability of these findings to people who, like Chris, when it comes to experience of etomidate, have a blank screen.
Let's answer those two. I'll jump in and say that, Paul, I support your proposal for the RSI ANZ trial that will randomize 100,000 patients to ketamine and versus etomidate when the two countries approve their use. Is that what you just suggested?
Not exactly.
I thought he was suggesting that he hadn't learned his lesson from the prior sessions about avoiding stepped wedge trials.
So I think you're exactly right that there's a huge opportunity to evaluate this, and I think, so I don't know how that governmental piece works, but if there's not sufficient evidence on this question for the regulators who approve drugs in countries where these drugs are not available, and the best available evidence suggests maybe that drug should be used, that strikes me as opportunity, and it would be a disservice to just not let that drug be available indefinitely because of historical concerns. So I think there's probably is some opportunity for research there. On your question about how easy is it to use etomidate, if you've never used it, etomidate is the easiest drug in the world to administer, and so for us, we used more etomidate than ketamine, and it was a real learning curve. You know, when ketamine first started being introduced in our practice in 2012, the patients, when you give etomidate, the patient's blood pressure remains the same, their heart rate remains the same, and they're just fully unconscious immediately. And that's not true of ketamine, right? Ketamine has pretty variable responses, and so it was a learning. It was definitely much harder just clinically for us to understand how to innovate with ketamine than it is with etomidate.
Yeah, okay.
I'll jump in there too and say that, I say again, that I'm struck for this extremely common high-risk procedure, how much variability there is in how people do it. So part of our inspiration to this work was that within our hospital, the way people were intubated in the emergency department was totally different than the way they were intubated by pulmonary-led medical ICU units and by anesthesia-led surgical units. So 3 totally different approaches for the exact same patient. And there had to be differences. And now we've done a series of trials that show that for some decisions, bougie versus stylet, it probably doesn't matter. And for others, it does. And I think this is one in that category. And there are learning phenomena we may have to overcome, but I don't think it's a good excuse to say, I'm going to continue doing something indefinitely and teaching my colleagues and trainees to do something indefinitely that I know is inferior just because it's the way I've done it before. And we've heard inertia like that over things like ultrasound guidance for central lines and video laryngoscopy. And I think that's a weak argument overall, and in this case, I think it's even weaker in that there's not much of a learning curve for these medications. They're pretty easy to learn how to use.
Okay, so any more comments or questions from, yeah, Alyssa?
Just to take things in a slightly different tact. I wanted to ask you to explain a little bit about your approach to assessing heterogeneity of treatment effect. So you used the standard approach of subgroup analysis, but then you also did a couple other things that I thought were quite innovative, including the predictive model that you used with the machine learning approach. And I was just wondering if you could maybe just explain what you did and why you did it and where you see the future of that method going.
Yeah, so this is, we were joking, an Easter egg that's buried in this trial, deep in the supplement, that wouldn't otherwise come to attention without a very attentive reader. So in clinical trials globally, clinical trials are a God's gift to man in terms of knowing the causal effects, but they have a huge limitation, which is clinical trials have always presented average treatment effect as if all patients respond the same. And as clinicians, we know that they don't. And so there are, I think in critical care, we're at this tipping point where everybody's trying to figure out how do we make these trials deliver personalized results. And one of the approaches to do that we've been working on with Paul and with our colleagues, Matt Cherpek at Wisconsin and with others, is that using that main lever in a trial, which is randomized trial group assignment, and combining that with these new machine learning methods that can take the vast array of baseline characteristics you measure and ask the question not, oh, is ketamine better in sepsis, but hey, if you have an 80-year-old with septic shock and AKI who's already on high-flow nasal cannula, what's the right drug for that patient? So an individualized treatment effect. And our hope would be eventually randomized trials. The product of that is not some average yes or no, but it's a model that just says, hey, for this patient with their 25 baseline characteristics, this is the point estimate of treatment effect for that patient. Here's the confidence intervals and a personalized output. And so this was our first attempt in a live trial to do that. And so you might immediately hear this and think, well, this is machine learning, this is a black box, I don't trust it, and that's the right answer. So how do we know that these are generating reliable estimates? The way we took that on in this trial was the first 1,700 patients we enrolled, we took all of their data on baseline characteristics, trial group, and outcome, and shared them with an independent analytic team at the University of Wisconsin. So nobody affiliated with the trial, and they derived a model using machine learning that would estimate the treatment effect for every individual patient using that derivation cohort before we had enrolled the remaining 664 patients in the trial. So there's no way to cheat and test the outcomes because those patients hadn't been enrolled yet. And then only at the end of the trial, they took that lock model, they shared it with an honest broker, a journal editor, and then with our team, and two separate teams basically took the data from the last 600 patients in the trial and fed it into that model. And so for every individual patient predicted, hey, this is a patient we think would have a 10% benefit from ketamine. This patient would have a 7% benefit from etomidate. And then we used that to see were those predictions right and as a baseline variable for heterogeneity of treatment effect. And the short answer in the trial, you saw it in that figure John breezed by, that model appeared to have go in the right direction broadly, but the confidence intervals were huge. And so unlike other trials, like Carol Hodgson's team trial and others that have been recently published that do have a huge amount of heterogeneity between the individual patients, we basically did not see any of that in the RSI trial. And this is our first time doing this live, but one of the things I found really interesting and reassuring is oftentimes when you have a trial that's negative, there's a lot of uncertainty left about, oh, what about sepsis? What about my favorite subgroup, right? And this for a negative trial ups the level of certainty a little bit, which is we didn't find no difference on average. We tried to find differences for any individual patient and essentially couldn't. So I'll get off my stump speech, but we're very interested in individualizing the results of trials, and Matt Cherpek and his team at Wisconsin are happy to talk to anyone about these methods and teach anyone how to do this. We hope it's a path towards personalized critical care.
Yep. Do you ever think we'll be randomising patients based on the black box model?
That's a huge future step, yes. So for those who are interested in trials, holy grail might eventually be that you're learning from the trial as you go, and that personalized estimates inform the conduct of the trial, but I think we are a long ways from that today.
Well, Matt's being too modest here, and I think there's a relevant collaboration sitting here that's worth talking about. So both Matt and Paul conducted trials of oxygen targets, the pilot trial and the ICU ROCKS trial, that found no difference overall between high and low oxygen targets. However, applying these methods in pilots seemed to identify patients who would benefit from both high targets and other patients who benefit from low targets. But my immediate reaction as a trialist and skeptic was this is all overfitting. There's no way that this actually is real. But it's a model, and like any model, what you do to evaluate it is an external validation. So they partnered with Paul and got the results of the patients from ICU ROCKS and tried to say, can you use that same locked model and identify patients in a second trial who would have had benefit or harm from high and low oxygen targets, and you could, and those results were published in JAMA last year. And to us, that was not sufficient evidence that we should go put this into practice, but it was sufficient evidence that we need to evaluate this in a trial. So maybe someday soon we'll be back here talking about Matt's Express trial. So that model now lives in our electronic health record at Vanderbilt, and every day it's calculating what patients it thinks should be receiving high targets and which patients it thinks should be receiving low targets, and that information is currently hidden from clinicians. And starting next year, we have a randomized trial for 3,000 patients where they'll be randomized to either personalized oxygen targets as identified using these machine learning models or usual care. And we'll see. I think that'll be one of the first tests of, do these methods actually improve outcomes for patients?
Wow, very cool.
So we've only got just a few more minutes left, so I'm going to go to the floor now, and Colin's got his hand up waving there.
Thanks, Paul. Thanks, guys. That's really fantastic work. You talked about the need for a bit of a learning curve for ketamine when you switched over to it, and it's always been a bit of an aphorism in anesthesia that it's not so much the drug that you select, but how you use it. I wonder if overall, across all of the trial sites and the clinicians involved, whether that learning curve was a factor. People were less familiar with ketamine and didn't know quite how to dose adjust appropriately, and that maybe influenced the outcome.
Were you reviewer 3? That was a question that came up, and there are lots of ways you can think about looking at that, but at least one way is by saying, did the treatment effect change over time during the trial? Did people learn in a way that changed the effect of the two trial groups? And the answer was no. So there was no difference over time, as there was no evidence of a learning phenomenon during the trial.
Sounds like they couldn't hear you.
So just to answer the question again.
Ketamine's fantastic.
Right.
Chris cut his mic.
That's right. That's right. I think he tried to dissociate everyone all at once.
Mic back on.
There was, in the trial analysis during the review process, people asked about learning phenomenon, and one way you can look at that is to look at the effect estimate over time and say, was there a learning that occurred such that it appeared by later stages in the trial one group was showing benefit that hadn't been present earlier, and there was no evidence of that in the trial.
Okay, Sam.
Yeah, thank you so much for disseminating your results in this forum. It's been really great listening to the conversation. I have perhaps applying a practical and logistic cap to this, and not having used obviously etomidate in our ICUs. Ketamine is kept locked away in our drug of dependence cabinets. It's a Schedule 8 drug, so it needs 2 nurses to check it out. I'm assuming etomidate sits on the shelf and is more readily available. And what's the cost difference between the two, and are you going to do cost-effective analysis?
That's a great set of questions. So our medication dispensing cabinets in each of the study ICUs contained both ketamine and etomidate, and so I don't think we have those requiring 2 nurse access or any of the protections around either of those 2 drugs. So that wasn't a factor that came up.
You're asking the wrong people as lame clinicians who just ask for things and magically appear at the bedside. Right. But I'll tell you that both the ketamine is recognized in the U.S. commonly as a drug of abuse, and I think may have additional protections like a lot of the narcotics do. I never thought etomidate was a drug of abuse, and it was only in preparation for this talk that our colleague in France, Jonathan Freund, sent us a picture from his trip to China in which there were all these signs about etomidate, and we learned that etomidate in China is a drug of abuse that youth are using and putting in vape pens, and it's led to a number of fatal cases. So I think, unfortunately, that may not be an advantage, particular of etomidate. I think there also is risk of diversion with that medication.
And the cost between the two?
So the cost, so these drugs have each been generic for more than 40 years. So at least in our settings, these are pennies on the dollar. These are both medicines that have almost no cost. So we've not done a cost effectiveness analysis, but any effectiveness is the cost effectiveness, if that makes sense.
Okay, so that's the end of the session, everyone. I'd like to thank the members of the panel for doing a great job.